Yes, good morning, everyone, and thanks for being here today. First, I would like to introduce a little bit about Center for My Study, or CKS. CKS is a non-profit and non-governmental organization working to promote research, teaching, and public service in the social sciences, arts, and humanities in Cambodia and the Mekong regions. CKS is also a member of Council of American Overseas Research Center. Today, we have Derek Richardson as our speaker. Derek is a PhD candidate in sociology at Indiana University Bloomington, and he is in 6 years of the program. His research focuses on global health, professional identities, and cross-cultural collaborations. He spent 16 months in Cambodia doing fieldwork with a comparative ethnography of 3 different NGOs that provide healthcare services. And his research looks at how foreign healthcare volunteers bring in their medical knowledge and how they adopt it when working with Khmer professionals and patients. His dissertation is called Foreign Expert Local Problems, and it digs into the challenges and dynamic of doing medical work across cultures and systems. Direct us an important questions. How do these professional and organization they work with manage the application of medical expert in new, uh, unfamiliar setting? So with that, let's welcome Direct and hear more about this fascinating work. Direct, the floor is yours. You have around 45 minutes. Thank you.
Thank you. Thank you very much for the introduction. And hello, everyone. Thank you for attending this webinar to learn about my research. And thank you to the Center for Khmer Studies for supporting my research and creating this platform for sharing findings and spreading knowledge. My name is Derek Richardson, and I am a sixth-year sociology PhD candidate from Indiana University Bloomington in the United States. My research topics, as already described, broadly include global health, organizations, and international development, and I tend to more narrowly focus my research questions on non-governmental organizations, or NGOs, in Cambodia. My presentation for today's webinar, titled Managing Patients and Impressions, How Transnational Healthcare Professionals Import and Adapt Medical Expertise in Cambodian NGOs, comes from 16 months of field research in Cambodia, in which I conducted ethnographic observations and interviews in 3 different NGOs that provide healthcare services. The first 10 months of my research was supported by a Fulbright Fellowship, and the last 6 months were supported by CKS. So thank you again for funding my research. I returned to the United States to begin data analysis and writing up my findings about a month ago, so much of what I'm presenting today is a work in progress. I'm still coding my field notes and interviews and testing out different arguments, but the presentation I prepared today entails an argument and theoretical framing that I'm fairly confident will persist in my dissertation. And so, yes, my fieldwork in Cambodia was for writing my dissertation in sociology. I defended my dissertation proposal in the spring of 2023, but the research questions I posed in my proposal ended up being very different from my current research direction. My original intention was to compare large, big budget, highly bureaucratized NGOs like Save the Children, Oxfam, World Vision International, to small scale, low budget, informally organized NGOs that are founded and led by ordinary citizens, laymen who are not NGO or development professionals and do not have professional credentials in international aid delivery. By comparing these 2 types of NGOs and studying their organizational forms and activities, I was hoping to understand how NGO workers and volunteers define their expertise, put expertise to use, and are perceived as experts, as indicated by the 3 research questions listed on this slide. Once I arrived in Cambodia and gained access to the NGOs that would constitute my cases, though, I quickly realized that the distinction between a professionalized versus an amateur NGO is very blurry. I therefore needed to pivot and formulate a new research question that would make comparisons between and across the NGO cases meaningful. Before presenting my new research question, allow me to first introduce my NGO cases. Note that the names of these organizations, as well as the names of the staff and volunteers that appear later in this presentation, are pseudonyms to ensure anonymity. I began and ended my fieldwork with Surgery NGO in Phnom Penh. It was established in 1998 and operates on a budget of approximately $1 million US. Its activities are primarily focused on reconstructive surgeries, namely orthopedic surgery and plastic surgery, but also includes ophthalmology, which is healthcare for eyes and vision, as well as otolaryngology, which is healthcare for the ears, nose, and throat. Surgery NGO has about 80 paid staff. Some are part-time, some are full-time. Some are healthcare professionals like surgeons and nurses. Others are administrators, accountants, cleaners and cooks, and maintenance workers. The NGO also hosts Khmer medical students to provide them with training opportunities. So including the students increases the personnel volume closer to 100 in total. Surgery NGO also hosts foreign volunteer surgeons to assist with treating patients and training Khmer staff and students. The foreign surgeons come from countries in the global north, like the United States, England, France, Austria, Norway, and many others, and they typically volunteer for 1 to 2 weeks at a time. Also, these are generally not one-time volunteers. Most of them return to Surgery NGO at least once a year, but oftentimes several times a year, for instance, once every 6 months. Interestingly, Surgery NGO does not actively solicit volunteer opportunities to Northern surgeons, and there is no application process to become a volunteer. All volunteer surgeons are either personal acquaintances with the NGO director and senior staff, or are friends of friends. I make this point simply to contrast Surgery NGO from other NGOs that organize surgical missions and widely advertise volunteer opportunities to surgeons in northern countries. Essentially, if you're a surgeon and do not personally know the NGO director or other senior staff, then it would be highly unlikely and very difficult to volunteer with this NGO and provide care. My next case is Lake NGO, which is based out of Siem Reap, but provides healthcare to floating villages on the Tonle Sap Lake. It does so by building its own floating clinics on the lake within the villages it serves and traveling there by boat for weekly 3-day missions. For example, the NGO staff leave Siem Reap on Monday morning. They work from their floating clinics on the lake for 3 days and then return to Siem Reap on Wednesday afternoon. Staff and volunteers provide care, eat, and sleep together within the floating clinics. Lake NGO is comparatively younger and smaller than Surgery NGO. It was founded in 2007, employs about 25 staff, and has a budget of about $375,000 US. Lake NGO also has 2 major types of activities. There are its clinical activities, which involve providing primary care and reproductive care to patients. For instance, treating hypertension and diabetes, treating stomach aches and headaches, and providing antenatal care. Then there are its outreach activities, which include installing water filters for clean drinking water, monitoring childhood malnutrition, and providing counseling for villagers struggling with mental health issues and domestic violence. Lake NGO also involves volunteer healthcare professionals from the global north in its activities, but in a way that is quite different from Surgery NGO. Rather than having short-term but frequently returning volunteers like Surgery NGO, Lake NGO has volunteers who assist on a long-term basis, usually 1 to 6 months, and generally do not return for additional volunteer stints. Some do, but it's quite rare. Lake NGO can also only host a few volunteers at a time, generally no more than 5, due to space constraints in the boats and the floating clinics. My final NGO case is Mission NGO. If I had stuck with my original research questions, this organization would most clearly exemplify an amateur citizen-led NGO. Mission NGO is led by a nurse from Australia and has no in-country facilities in Cambodia. The leader organizes short-term mission trips in Cambodia, usually once a year and usually lasting one or 2 weeks to provide primary care, and invites other Australian healthcare professionals to come to volunteer with the NGO. Its budget varies from trip to trip, but for the time I spent observing its activities and interviewing its volunteers, it had approximately $5,000 at its disposal. Most of Mission NGO's work has been in Tikal because the leader is friends with the director of a public hospital there, but through other personal friendships and connections, the leader also organizes healthcare provision activities in Phnom Penh and other provinces. After gaining access to these 3 NGOs and learning more about their structures and activities, I noticed the differences I just described in terms of staff size, budget, location, and modes of healthcare provision. I didn't want to treat these NGOs as individual cases. I wanted to make comparisons across them, so I needed to find something that they each have in common to make the comparisons meaningful. The most notable common characteristic is that they all depend upon the expertise of volunteer healthcare professionals from the global north when providing healthcare services. Realizing this, I then began directing observations and interview questions toward understanding how NGOs attract foreign volunteer healthcare professionals to provide care in their organizations, and what the foreign volunteer healthcare professionals do once they arrive in Cambodia and begin working in the NGO. Before proceeding to my findings, allow me to further explain my methodological approach. As I stated, I relied on ethnographic observations and interviews to collect my data. Concerning observations, I was mostly interested in interactions, namely between foreign volunteer healthcare professionals and Khmer healthcare professionals, between healthcare professionals, be they foreign or Khmer, and their patients, and finally between NGO staff and external stakeholders like donors, government ministries, and other collaborative partners. I wrote extensive, highly detailed field notes from my observations of these interactions, both in real time and within 24 hours of leaving the NGO's facilities. And I'm currently still in the process of analyzing these field notes using a combination of hand coding techniques and qualitative data analysis software. Concerning interviews, my interviewees generally belong to one of 3 categories: the foreign volunteer healthcare professionals who travel to Cambodia from the global north to volunteer their medical expertise, the Khmer healthcare professionals who work in the NGOs, and the non-medical Khmer staff, such as administrators and accountants who also work in the NGOs. My interviews with these 3 groups followed a semi-structured approach. The topics I asked about correspond to interviewees' specific roles and experiences in the NGOs. With my foreign volunteer healthcare professional interviewees, I asked them about their motivations for volunteering in Cambodian NGOs, basically why and how are you here, their education and training backgrounds in the global north to understand what kinds of medical expertise they offer NGOs when volunteering, their roles as volunteer healthcare professionals in the NGO, and how they perform that role vis-a-vis Khmer healthcare professionals, and whether and how they adapt their medical expertise when applying it during healthcare provision in the NGO. When interviewing Khmer healthcare professionals who work in the NGOs, I asked them about their motivations for working in an NGO instead of a public hospital or a private clinic, their education and training history in Cambodia and abroad, their thoughts about working alongside foreign volunteer healthcare professionals, and work routines and organizational structures that influence how they go about treating patients and interacting with foreign volunteer healthcare professionals. Finally, my interview questions with the non-medical Khmer NGO staff were mostly geared towards understanding how the NGO generates revenue to provide its services, which government ministries the NGO must respond to, and how their non-medical roles come to bear on the healthcare delivery process. All my interviews were audio recorded and transcribed for analysis, which, as with my field notes, is an ongoing process. In sum, across my 3 NGO cases and throughout my 16 months of fieldwork in Cambodia, I conducted nearly 1,000 hours of observation and over 150 interviews. You can see the breakdown of those totals in the table here. Since Mission NGO has no permanent in-country facilities and was only present in Cambodia for 2 weeks during my fieldwork, my observation hours and interview totals with them are comparatively fewer. And since I have far more data with Surgery NGO and Lake NGO, my analysis and forthcoming discussion of the results will focus on them. But again, before proceeding with presenting my results, allow me to state my modified research question that emerged from this fieldwork, which is, how do transnational healthcare professionals and the organizations in which they work manage the application of medical expertise in new settings? I phrased my research question to purposefully draw attention to 2 key elements. By including both the individuals and the organizations as objects of inquiry, I acknowledge and will show in this presentation that managing medical expertise requires joint coordination from these 2 different types of actors. Second, by including in new settings, I am making it explicitly clear that the volunteer healthcare professionals I'm studying are not working in their home hospitals, clinics, or medical centers, but rather are applying their expertise in an organizational setting that is different from where they commonly work. Working in a new setting, as I will show, creates distinct issues for managing expertise that ordinarily do not arise when working in a familiar setting. So now let's discuss what I found. And I think a logical place to begin is by addressing that second component of my research question. What is it about working in a new organizational setting that complicates the management and application of medical expertise? In my analysis thus far, I've identified 5 factors related to the new organizational setting that complicate how foreign volunteer healthcare professionals fulfill their roles. I begin first with perhaps the most obvious, language barriers. Nearly all foreign volunteer healthcare professionals across the NGOs I studied have no or minimal Khmer speaking ability. Most commonly, they only know phrases like hello, 𝐀𝐿 and thank you, 𝐀𝐭. At best, they might know that pain means chu, but otherwise they are entirely dependent on English-speaking Khmer NGO staff to communicate with patients, and they primarily only interact with those NGO staff who have English-speaking skills. How this affects their ability to apply medical expertise is fairly clear. In the first quote, Dustin, an American orthopedic surgeon volunteering with Surgery NGO, explained that he is worried that his ideas about whether and how to treat patients gets lost in translation or aren't accurately translated when he needs to communicate with both patients and other NGO staff. It's a source of anxiety that he must manage when planning and providing care. The second quote is from Ron, a British medical student who volunteered with Lake NGO, where it's years to work side by side with Khmer medical staff. Since Ron doesn't speak Khmer, he explained to me that he couldn't ask the patients many questions during consultations, and since he couldn't understand patients' responses to the Khmer NGO doctor's questions, he needed to trust that the Khmer NGO doctor's judgment and diagnosis was correct. As he says, I wouldn't disagree. I'd be like, fair enough. The language barriers greatly reduce the amount of information that foreign volunteer healthcare professionals receive and impart to make expert medical judgments, thereby minimizing how they can fulfill their roles as medical experts. Another constraint that the NGO setting impose upon foreign volunteer healthcare professionals is that they are often not equipped with the same resources that the volunteers are used to having in their countries of origin. This includes resources to help make diagnoses like imaging technologies and laboratory tests, and resources to treat patients like medications and surgical tools. The following is an excerpt from my field notes that demonstrates the effects limited resources have on volunteer health to repair broken bones. You can see in the bolded lines, she tells him, don't expect anatomical plates here, they don't exist. She also tells him that nails get put in with no x-rays and that screws get recycled. Things that, in her words, would be a big no-no where we come from in the global north. Dustin tells Beth that they might need to MacGyver the surgery, meaning that they will need to be creative in how they go about treating the patient's broken bones in the absence of resources that they take for granted in their home countries. That is, Dustin and Beth will need to adapt their medical expertise to perform their roles as medical experts in the new NGO setting. Third, foreign volunteer healthcare professionals must often treat different and/or more severe illnesses than what they're accustomed to encountering in their home countries. Tim, the director of Lake NGO, explained that actually in the floating villages on the lake, patients' conditions aren't very different from what is typically found in the global north, but the illnesses have typically progressed to a more advanced, severe stage. At Surgery NGO, patients' conditions can be both more severe, as a British ENT surgeon explains in the second quote, and unfamiliar, as a Singaporean microsurgeon explains in the third quote. The second quote by the British ENT surgeon is especially illustrative because he makes the implications clear for performing the role of medical expert. Treating an unfamiliar illness puts foreign volunteer healthcare professionals at the edge of their skill level. A fourth constraint is that foreign volunteer healthcare professionals are used to performing their roles in their home countries where they are familiar with the culture, specifically cultural beliefs about what constitutes appropriate medical care. When they work in NGOs in Cambodia, though, they quickly realize that Khmer patients have different cultural beliefs and preferences about medical care, and they are not always prepared to navigate the unfamiliar cultural terrain. This slide contains an excerpt from my field notes that documents a conversation between two British orthopedic surgeons, Angie and Carly. In the excerpt, Angie explains how if she were back home in England, she would amputate a patient's toe. But since she is in Cambodia, she doesn't know if amputation is the best course of action. The second bolded line is the most exemplary. She says, back home, I know I'm picking the right surgery for the right patient. But here in Cambodia, she says, the one thing that has me worried is the cultural thing and how the patient and others would respond to living with an amputated toe. This issue is not unique to Surgery NGO. During an interview with Leia, a Norwegian general practitioner who volunteered at Lake NGO, she explained how she isn't sure which questions about reproductive health are culturally appropriate to ask patients. She explains that in Norway, she would normally ask women patients about their sexual partners, contraceptive use, and other sensitive topics. But while volunteering with Lake NGO, a Khmer NGO doctor explained to her that those questions are inappropriate and need to be asked differently. And yet again, not being able to ask these questions complicates how foreign volunteer healthcare professionals perform their roles as medical experts. Finally, the foreign volunteer healthcare professionals are used to spending more time with their patients and discussing treatment options at length with patients and other medical experts in their home countries in the global north. When they work in Cambodian NGOs, however, these types of conversations and deliberations often occur in a matter of minutes. Emma, a Swiss general practitioner who volunteered with Lake NGO, mentioned the time issue in my interview with her, saying, "We didn't have enough time to discuss in detail the patient's complaint compared to what I would normally do in a consultation." Neil, a Singaporean hand surgeon who volunteered with Surgery NGO, raises a similar point about limited time, but adds that he would ordinarily seek advice from other medical experts when making treatment decisions and planning surgeries, specifically a multidisciplinary team with therapists and surgeons. These constraints, as Emma says, force the volunteer healthcare professionals to make adaptations to how they perform their roles as medical experts. Hopefully by now, one empirical finding should be clear. Cambodian NGOs are a new, unfamiliar organizational setting for foreign volunteer healthcare professionals, and features of the new setting constrain how they perform their roles as medical experts, which forces them to make adaptations to their medical expertise. But we've sort of bypassed a very important question. Sure, foreign volunteer healthcare professionals, by virtue of their professional status, are supposed to be medical experts. That is their role. But what are the expectations for fulfilling the role of medical expert in the new organizational setting? Let's begin by considering the perspective of NGO leaders, starting with Surgery NGO. In this interview with Marco, a British orthopedic surgeon who works full-time with the NGO and is a board member for the NGO, he explains in the first and second bolded sections of the excerpt that foreign volunteer healthcare professionals' main role is to teach the Khmer NGO staff how to perform surgeries on their own. He says the number one objective is the foreign team are here to teach. He notes that some foreign volunteer healthcare professionals are more proactive and effective teachers than others, and that some simply come to do surgeries independently. But as we can see in the last bolded section of the excerpt, he says that that's the wrong approach. Andy, the director of Surgery NGO, reiterates this point by saying that if there is ever a discussion about who should do a surgery, a foreign volunteer or a Khmer NGO surgeon, priority should always be given to the Khmer NGO surgeon. When I asked him why that is, he says because the foreigners don't belong here, can't speak Khmer, and can't speak to the patients. And at the very bottom of the excerpt, they're here to teach the Khmers how to do things. At Lake NGO, foreign volunteer healthcare professionals play a similar role. These quotes come from two separate interviews with the NGO director, Tim. In the first quote, Tim says that the foreign volunteer healthcare professional's role is primarily to teach and to learn. In the second quote, he, like Andy from Surgery NGO, wants them to play a subordinate role to the Khmer NGO staff, so the NGO does not become dependent on volunteers. He adds, though, that the foreign volunteer healthcare professionals are also very good for morale. When asking the foreign volunteers about their roles and what they're expected to do, I received mixed responses. There was more certainty and clarity from the volunteers at Surgery NGO. In the quote here, Dustin, the American orthopedic surgeon, practically repeats what Andy had told me about volunteers' roles, that Khmer surgeons should be the main people doing the cases, and that the volunteers should be training NGO staff. At Lake NGO, though, foreign volunteer healthcare professionals were less certain about their roles. In the first quote, Emma, the Swiss general practitioner, tells me that she needed to ask a Khmer NGO doctor what was expected of her while she was on the bus headed to the boats that the staff take to get to the floating clinics, because it was not clear what my role was. Similarly, prior to arriving in Cambodia, Leia, the Norwegian general practitioner, told me that she feel like she didn't get any information about what it's like to be a volunteer. At both NGOs, though, If the foreign volunteers were medical students and not fully trained healthcare professionals with medical degrees, then the role expectations were especially unclear. I have lots of examples that illustrate this point, but I chose these quotes from Annie, a British medical student who volunteered with Lake NGO, because she describes the uncertainty very clearly. She begins by questioning the necessity of her role, saying, "The person sat next to me is a fully qualified doctor. They can do this job, but without the help of a translator. How helpful am I being?" She then explains how a fully trained volunteer healthcare professional like Nigel, a British general practitioner who she mentions in this quote, can better meet role expectations of teaching NGO staff new things. She told me that Nigel comes and basically imparts various aspects of wisdom, like he taught them how to use the ultrasound. She concludes by returning to her primary concern. As a final year medical student, there's probably less to learn from me. In my head, I don't know how objectively helpful I'm being. So evidently, there is variation in the extent to which foreign volunteer healthcare professionals understand what is expected of them when they come to volunteer in Cambodian NGOs. Seemingly, the foreign volunteer healthcare professionals at Surgery NGO have a better grasp on their role expectation than those at Lake NGO, but in both cases, medical students experience a high degree of uncertainty. Of course, though, regardless of whether they understand what is expected of them, they must meet role expectations in a new, unfamiliar organizational setting, which has its own set of constraints that complicate how foreign volunteer healthcare professionals perform their roles. So, what happens? How do foreign volunteer healthcare professionals adapt their medical expertise to make it applicable and meaningful in Cambodian NGOs? I argue that in order for foreign volunteer healthcare professionals to successfully perform their roles as medical experts, they must adopt impression management strategies, strategies that involve interactive coordination between the volunteers and their organizational settings. I'll describe these strategies in a moment, but let me first explain what I mean by impression management. Impression management is a term coined by American sociologist Irving Goffman, who uses theater as a metaphor for social life. He believes social actors, be they individuals, organizations, or some other entity, have roles that they must perform. For instance, a teacher's role is to educate their students. A government's role is to govern its people, etc. These social roles are not performed in isolation, but rather are performed interactively with other social actors. Those other social actors constitute the audience of the performance. In the previous examples, for the teacher, the audience is the students, and for the government, the audience is its citizens. Through interactions, actors and their audiences perform their social roles, and by doing so, create and sustain meanings for understanding social life. Importantly, Goffman extends the theater metaphor by arguing that social actors have a front and back stage. An actor's front stage are those public spaces where they encounter their target audiences and perform their social roles. An actor's backstage, in contrast, is a private space, hidden from the audience's view, where actors prepare themselves to perform their roles. How social actors manage their front and back stages to perform their roles is what Goffman means when he uses the term impression management. In the context of my study, the social actors of interest are the foreign volunteer healthcare professionals. They have roles as medical experts, which, as I previously showed, involves treating patients and training NGO staff. Patients and staff thus constitute the audience of foreign volunteer healthcare professionals' front stage role performances. And through their collective interactions, all the actors involved reach an understanding of what it means to deliver healthcare and effectively treat patients in Cambodian NGOs. And so I identified several impression management strategies that foreign volunteer healthcare professionals adopt to facilitate role performance in a new, unfamiliar organizational setting. The first strategy is that foreign volunteer healthcare professionals maintain a confident front stage demeanor to facilitate their role performance of medical expert. The first quote is especially telling. Aaron, an American ophthalmologist, volunteered with Surgery NGO for a week to perform cataract surgeries. When I observed Aaron operate, he frequently said that the surgeries were going well despite some minor issues. For instance, issues with the equipment or issues communicating with the NGO staff. Despite these issues, Aaron says here in my interview with him that patients can sense that there's anxiety in the room, and if that happens, then they start worrying that something's wrong. To prevent patients from worrying, Aaron manipulates his front stage presentation to create a sense of calm in the OR, which he says translates to the patient. Meanwhile, Troy, an Australian medical student who also volunteered at Surgery NGO, also talks about putting on a confident front, but in a very different context. During my interview with him, Troy was telling me that since he's still a medical student and not a fully trained surgeon, he cannot accurately judge the appropriateness of the decisions that the fully trained surgeons reach, be they foreign or Khmer. He says, though, in this excerpt from our interview, that if the surgeons project a certain confidence and understanding, then people around them will feel more comfortable to trust their judgment. Thus, in the first example, Aaron, the surgeon, manipulates his front stage performance to appear confident, and that confidence helps his audience, Khmer patients, perceive him as a credible, legitimate medical expert performing his role correctly. In the second example, the audience is instead medical students who, by observing senior surgeons' confident front stage performances, trust that they are performing their roles as medical experts successfully. The second strategy involves another term from Irving Goffman called saving face. Goffman states that when an audience observes something about a performance that is inconsistent with the performer's role expectations, performers will attempt to adjust or change their performance to realign it with role expectations and successful role performance. I had to put my example of this in the next slide because it's a lengthy excerpt from my field notes inside the operating room. And so here, the operating room at Surgery NGO has 3 beds so that 3 surgeries can happen at the same time. In this excerpt, Sung, a Singaporean hand surgeon, is operating at the 3rd bed. He's almost finished with his operation. He's trying to suture up the wound on his patient's hand, but he's struggling. At the top of the excerpt, you can see him ask for help with the suturing. Then Andy, the NGO director, enters the operating room. He goes from bed to ask the foreign volunteer healthcare professionals if they are almost finished with their surgeries because more patients are scheduled for surgery today and need to be operated on. In other words, there's a time constraint, and Andy needs the foreign volunteer healthcare professionals to work quickly. At the bottom of the excerpt, Andy starts walking towards the bed where Sung and his team of surgeons is working. Sung frantically tells the staff around him, "Go, go, go," to finish suturing the wound closed before Andy arrives. When Andy arrives and asks Sung if the surgery is finished, Sung answers, "Done," and Andy says, "Good." Here, in Sung's performance, he is worried that Andy, his audience, will see him failing to meet role expectations. Sung saves face by rushing through the final sutures, so that by the time Andy arrives, it looks like there were never any issues at all and that he is still working according to schedule. A third strategy concerns the physical appearance of foreign volunteer healthcare professionals. At both NGOs, NGO staff and foreign volunteer healthcare professionals wear clothing that indicate to their audience, the patients, that they are medical experts. At Surgery NGO, it's surgical scrubs, masks, and caps. At Lake NGO, it's matching uniforms that have the NGO's logo on it. During my fieldwork, I didn't need to wear Lake NGO's uniform since I am not a healthcare professional, but at Surgery NGO, I needed to wear clean surgical scrubs if I was observing inside the operating room or the recovery room where patients go after surgery. Because my public front stage performance involved me wearing surgical attire, patients frequently perceived me as a medical expert. Consider the following excerpt from my field notes. Here, I was in the recovery room with a Khmer anesthesiologist who was explaining to me how he treats patients when they wake up from surgery. During our conversation, a Khmer man enters the room, gets my attention, and shows me a piece of paper that has patient information written on it. He then gestures for me to come follow him outside the recovery room. I thought the man was NGO staff who I hadn't met yet, so I followed him. The man leads me to a patient who looks at me with a nervous, exasperated expression. I realize the man must think I'm a doctor since I'm wearing scrubs. I tell the man in Khmer that I am not a doctor and I return to the recovery room. Evidently, because I'm wearing surgical scrubs and therefore giving off the front stage appearance of a medical expert, patients misunderstood my role and treat me like a medical expert. Importantly, though, it's not just that I was wearing surgical scrubs that caused the confusion, but also I consistently found that patients are more likely to perceive white foreigners as medical experts than non-white foreigners and Khmer NGO staff. It was apparent in that excerpt from my field notes. The Khmer man could have instead asked the Khmer anesthesiologist, who was also wearing surgical scrubs, for help, but instead he came to me, a white man. And in case you don't believe me, here's evidence from the Khmer NGO staff themselves. In this excerpt from my field notes, I was eating lunch with Marco, the British orthopedic surgeon who works full-time at the NGO, and other Khmer NGO staff. Lately, there had been far more patients coming to the NGO than usual, so Marco asks the NGO staff why that is. One of them says it's because a French surgical team was here recently. Another explains that the NGO made a post on its Facebook page announcing that foreigners are coming and says, most of the patients come because they would like to see the foreigner. I have plenty of examples of this from my observations and interviews with Lake NGO too, but the point is that one's racial identity and nationality, that is, being white and from the global north, is an element of one's physical appearance, which patients interpret as signifying medical expert. A final impression management strategy is that both foreign volunteer healthcare professionals and Khmer NGO staff attempt to reproduce medical professional status hierarchies that exist in Northern healthcare organizational settings. By that, I mean there is typically a chain of command that corresponds to one's level of medical training. In the simplest hierarchy, which is demonstrated and reproduced within Lake NGO, doctors oversee nurses and/or medical students who oversee patients. In surgical contexts, the hierarchy has more layers. A senior surgeon oversees a junior surgeon who oversees nurses and, if present, medical students who oversee patients. Across contexts, when care is provided at a lower level in the hierarchy, like by a nurse or a medical student, it generally needs to be checked by someone at a higher level in the hierarchy, like a doctor or a senior surgeon. I found that the foreign volunteer healthcare professionals in both NGOs attempted to reproduce these medical professional hierarchies despite the various constraints the new setting confers. At Surgery NGO, Carly, a British orthopedic surgeon, brought along one of her junior surgeons, Lucy, who is a first-time volunteer. She explains to me that even though Lucy is unfamiliar with the new setting, there's still a hierarchical structure within teams, which, as she says in the second bolded section, makes successful role performance easy. Similarly, at Lake NGO, since Annie, a British medical student, is at a lower position in the medical professional hierarchy than the Khmer NGO doctor, she explained to me that she would mostly agree with the Khmer NGO doctor's judgments and diagnoses, saying she would translate, she would offer up an opinion as well, which, by and large, I would agree with. Evidently, then, Annie relies on the medical hierarchy to successfully perform her role as a medical student. She defers her expertise to the Khmer NGO doctor who has more training than her and is more familiar with the organizational setting. By doing this, she avoids situations where she might need to save face, since she is staying within her position in the medical hierarchy in Cambodia as she would in the UK. Now, as I conclude this presentation, let's return to my research question. I asked, how do transnational healthcare professionals and the organizations in which they work manage the application of medical expertise in new settings? Practically, this is an important question to ask because the foreign volunteer healthcare professionals are trying to treat Khmer patients and train Khmer NGO staff in conditions where there are varying degrees of certainty about expectations for role performance and where they need to perform their roles in an unfamiliar environment. I argue that they do this through impression management strategies, which require coordination between both the volunteer healthcare professionals and their organizational settings. I restate the impression management strategies here. The first two involve efforts on the part of volunteer healthcare professionals themselves. They must put on a confident demeanor in their front stage performance and attempt to save face when front stage performances fail. The third strategy is also an individual level effort insofar as factors like race and nationality are inherent and don't involve coordination with the NGO. Nevertheless, wearing NGO uniforms and surgical attire does involve coordination with the NGO. Volunteer healthcare professionals can only wear such attire in situations that the NGO deems appropriate, like for me when I enter the operating room or the recovery room. The fourth strategy requires complete coordination between foreign volunteer healthcare professionals and the NGOs, since reproducing a hierarchical chain of command requires manipulating work relationships between the volunteers and NGO staff. Both parties must understand how the hierarchy works and each other's positions within it. While these strategies empirically answer the question of how transnational healthcare professionals and their organizations manage the application of medical expertise in new settings, why should scholars care? I'm a sociologist. Why should other sociologists care? Most research on professionals, their work, and their mobility focus on a single country setting rather than transnational contexts. When professionals are trained in one country, work in that country, and then move elsewhere to continue working in that same country, they don't often face the same issues for role performance as do mobile transnational professionals. Generally, their role expectations and performance are the same. For example, if an American doctor is trained in an American medical school and works in a hospital in New York, but moves to California, sure, there might be some minor differences between the two hospitals and how they're structured, but ultimately the doctor is expected to continue his or her role performance smoothly. I've shown, though, that these findings don't hold when professionals who are trained in one country and are accustomed to working in that country move to a different country to perform the same work, especially when moving from the global north to the global south, where there are language barriers, limited resources, and other constraints. In such cases, professionals must adapt their expertise to the new setting, and I argue that they do that through impression management strategies. Thank you very much.
Thank you so much, Direk, for your fascinating presentation. So just for a very short summary, in your presentation, you share insight from your 16 months of ethnographic fieldwork in 3 different Cambodian NGOs, each with different sizes, resources, and also organizational structures. You also explore how foreign healthcare professionals, including medical students and experienced volunteers, adopt their role and navigate the reality of working in unfamiliar environment. So this is really interesting. Besides that, they also face challenges like language barrier, cultural differences, limited medical equipment, and time pressure. You also mentioned about one concept that have made sense of their experience is Irving Goffman's idea of impression management. So how these professionals present themselves as competent medical experts even when conditions are unclear. So what stood out most is how differently their roles are defined, especially for students, and how crucial it is for NGO and volunteers to work closely together to make healthcare delivery and knowledge exchange truly effective across culture. So thank you. This is really interesting. My first question is, it's a general question for you. What drove you to study transnational healthcare professional in Cambodia specifically?
So for a very long time when I was a student in college, I wanted to become a doctor and I wanted to not just work in the United States, but also work abroad. And when I was preparing to apply to medical schools, I got involved in research on NGOs in Cambodia, at which I didn't know that there exist NGOs that provide healthcare services in other countries. It was entirely new to me. And once I realized that, oh, these organizations exist, it made me really curious. It made me very interested. And so instead of going to medical school,
Yeah.
here I am in my sixth year of a PhD program studying these organizations and trying to understand how they work.
Yes. And what were some challenges you faced during your ethnographic fieldwork across the three NGO, for example?
I'm sorry, could you repeat that?
Yeah. My question is, what were some challenges you faced during your ethnographic fieldwork across these three NGO that you
Yeah.
study?
Um, One of the biggest challenges is that I wasn't focusing on one organization. I had in this presentation too, but there was that third organization as well. And when you're doing ethnographic fieldwork, it's really important to embed yourself in the organization that you're studying, to be there for a very long time, to earn the trust of the staff, to earn the trust of the volunteers. But since I was moving between organizations, moving from Phnom Penh to Siem Reap, I felt like the moment I was getting comfortable and the moment I was making those relationships, it was time to leave. But which again, I'm so thankful that the Center for Khmer Studies was able to fund my research again so I could come back and spend more time with these organizations, more time with these healthcare professionals so I could do this project. So that helped overcome the challenge. But indeed, that was a challenge, was maximizing the time that I had with each of these organizations.
Yes, thank you. We also have some questions from our audiences. The first one from Kosminski. I will read the question. Has any of the doctors questioned the importance of foreign physician and surgeon instead of employing local doctors who struggle to earn their living in Cambodia? Yeah.
That's a great question. So, the NGO leaders for these organizations, they make it very clear that they don't want the doctors or the surgeons to be doing work that the Khmer doctors can do by themselves or can do independently. That's why the focus is so much on teaching. So, for example, if there's a surgical technique that a Khmer doctor doesn't know how to do, the purpose of the French surgeon or the Norwegian surgeon is to teach that Khmer doctor how to do it. So once that French surgeon leaves or that Norwegian surgeon leaves, then the Khmer doctor can do it themselves.
Mm.
And what was an interesting finding from my research that didn't make it into this presentation, though, is that, you know, Khmer healthcare professionals, they can work in an NGO, but they could also work in a public hospital or in a private clinic. And sometimes they can earn more money by working in those other settings. So sometimes the volunteers would come and say, oh yeah, I trained 5 surgeons or I trained 5 doctors, this particular skill, but now they left the NGO to work somewhere else and make more money. So now I have to start from scratch. I have to start all over again and train new doctors how to do this skill, which on one hand, they would they would describe that with frustration, but they would also recognize though that like by giving these doctors these skills, that does give them opportunities to again advance their careers, to make more money and to live a more comfortable life. So that was something interesting that I didn't quite expect when I began this project. But that's an excellent question. I hope I answered it.
Thank you for your answer. We also have one more question from 𝐀𝐻𝐿𝐭𝐫𝐚𝐜𝐭. She said that she was in the middle of the presentation, but she also wondering about the name of the actors. Is it in your presentations, is it a real or a fake name?
They're all fake names. Yeah, in order for my research to be approved by my university, I needed to change the names of all of the organizations, all of the individuals. And that's also really important to going back to my point about building relationships and establishing trust with these people who I'm studying is like I don't want to share something that could possibly put them at risk, be it with their career or with their family or with the government. So it is really important that I don't use real names and that I do use pseudonyms or fake names. So yes, not real.
Yeah, yeah. In your presentation, you also mentioned about the some barrier for the foreign volunteer, foreign expertise. So I just wonder, how did local Cambodian staff view the presence of foreign volunteer in their clinics?
Very mixed. So because it like it really kind of depends on who the foreign volunteer is. Um, because some really go out of their way to become friends with the NGO staff and to really teach them, train them. And for example, even when they go back to their home countries in the US and France, they maintain communication through social media, through phone calls. But there are some other volunteers who um, don't put in that much effort to get to know the Khmer staff, and they're just there to treat the patients themselves, which again, that one NGO leader, I provided the quote. He said that's the wrong approach. That's not what they want from the volunteers, but it does happen from time to time. And so, yeah, sure enough, when I'm speaking with the Khmer staff, they might be like, oh, yeah, this particular volunteer wasn't so great, but it's definitely a mix. It's generally positive, though, especially if they are able to learn new things, learn new skills. And even more so if sometimes the foreigners are able to provide opportunities for the Khmer staff to come with them back to their home countries in the global north for additional training. So that is like an amazing opportunity for a lot of the Khmer NGO staff. So yeah, for example, some of the surgeons would go to France, they would go to Germany, they would go to Australia and get training opportunities that would never be available to them if these foreign volunteers did not exist. But it's kind of a spectrum of like amazing volunteers that the NGO staff love to volunteers that the NGO staff might say, maybe we shouldn't invite them back again next time.
Yes, yeah. And for your own opinion, how can NGO better prepare foreign volunteer before they arrive, and what are some best practices for ensuring more collaborative and respectful relationship between foreign and local healthcare workers to work together?
That's a great question, and a very important one. Um, I think I think one thing for both NGOs that like my sort of advice I would give to them is to give more preparation about what to expect before they arrive. Because oftentimes these volunteers will arrive in Cambodia and the same day or the next day they're treating patients, but they don't know what medications the NGO has, or they, again, don't know who they're going to be working with. They don't know the schedule of activities. For example, with Lake NGO, oh, we're going to go on a boat now. Oh, we're going to be on the boat for 3 hours and then treat patients. So I think if the volunteers knew what was going to happen before it happened, if they had a better sense of that, that would not only help them, but also help the NGO staff and help the patients too. Like I think everybody would win. So some there could be, I suppose, like room for improvement there. Um, and was there more to your question? I apologize.
That's okay. Yes, not a very different question. Another question from Kosminski. What did the foreign colleagues learn from the Khmer colleagues?
Great question. Yeah. So a variety of things. So, um, in a lot of in a lot of countries like the US, like France, there's this issue where healthcare is very expensive, and it's very expensive um, we because we have access to all of these technologies, to equipment like X-rays, and we have all of the pharmaceutical drugs that we could ever want. But because we have that access, we often order so many tests and we prescribe so many drugs, and it's very, very expensive. And because by working in like a low resource setting, if you will, like the NGOs in Cambodia, they tell me that when they go back to their home countries, they one thing they learn is how to treat patients more efficiently with respect to money. Like how can I treat patients back in the US, back in France with the same quality, but without it being so expensive? That was one thing that the foreigners would learn from the Khmer staff. They would also, though, learn how to treat conditions that are uncommon in their home country, which to me sort of raised a question where I'll give an example, like dengue fever. Um, Dengue is quite common in Cambodia. Um, it's becoming more common in the United States, but is pretty rare. And so I would often ask the doctors, I'm like, why is it so important for you to learn how to treat dengue fever if back home, you will only maybe see one or two cases in your entire career? Like, how does that help you? But for them, like they had two answers. It was, well, if I ever do get that patient, I will know how to treat them. I will be prepared. But it was also more about developing like critical thinking skills and learning how to like recognize and diagnose unfamiliar things. So more of like an abstract skill set that they are able to cultivate in Cambodia and then bring with them back to their home countries.
Thank you so much. We also have another question from Sanari. How long have the medical volunteer worked in your research NGO?
So with surgery NGO, some of those volunteers have been working at that NGO for 10, 15 plus years. And again, so like they come once a year or maybe twice a year. And because they come time and time again, they are familiar with like the resources, the staff. So when they do arrive, they can go, they can hit the ground running and provide care. But there was definitely a lot of first-time volunteers too. Those were the ones who struggled the most with working in that new setting, and especially with Lake NGO, because as I mentioned in the presentation, that usually those volunteers are only like one-time volunteers. Granted, they're there for a long time, usually several months. So it was interesting to watch them from like their very first time on the lake to like 3 months later. It's like they work way more efficiently. They have it all figured out. But yeah, there's variation between the cases about how much time the volunteers spend with each organization.
Thank you so much. Your presentation is really fascinating. So yeah, we have a lot of questions.
I'm glad.
Yeah. Another question from Song Tan. In all the NGO are all the medical care provided free of charge. How about medicines? Where are the funding from, governmental or foundation or donations?
Yeah, so both NGOs are dependent on donors, usually private foundations. Although Surgery NGO uses different like online like crowdsourcing websites where they'll post um, a patient case online, explain what surgery is needed, and then people can donate to pay for that surgery, basically. Um, at Lake NGO, all of the care is provided for free. At Surgery NGO, it is free or reduced cost. And so basically, they make that judgment about whether they pay or not, depending on the patient's income and what they could potentially afford. If the patient does need to pay, the NGO always makes sure that it would cost less than what they would pay if they were to go to a public hospital or a private clinic, or if they were to like leave the country to get care elsewhere. Um, yeah.
Yeah, I have no more questions. Just look at the question from our audience. If there is any, I think you answer all the questions. So thank you so much, Direct, for such a fascinating and thoughtful presentation. It was really interesting to hear how your research bring together personal observation, cross-cultural dynamic, and the reality of the healthcare work in Cambodia. I think many of us gain a deeper appreciation of the complexity of global medical volunteering and what it means to truly collaborate across border. And a big thank you as well to the Center for Khmer Study for providing these occasions and creating a space for this kind of important conversations. And thank you to everyone who joined us today. We appreciate you taking the time to be here. And if you have more questions or want to chat with Direct afterward, feel free to stick around and take care. And we hope to see you at the next session. Thank you so much. Have a nice day.
Akunjaran.
Conference.